Hey everyone, welcome back to Physical Remedy. Today, we're diving into a crucial topic for physiotherapists, athletes, and anyone dealing with shoulder pain, rotator cuff disorders. Rotator cuff injuries are incredibly common, especially in overhead athletes and older adults. But what actually causes these issues? And how do we properly assess them? Let's break it down. Segment 1. Understanding rotator cuff disorders. Rotator cuff disorders are multifactorial, meaning multiple factors contribute to their development. These include trauma, glenohumeral GH instability, scapulothoracic dysfunction, congenital abnormalities, and degenerative changes. We can divide the causes into two main categories: intrinsic and extrinsic factors. Intrinsic factors, primary tendon degeneration due to aging and poor vascular supply. Extrinsic factors, mechanical compression of the rotator cuff between the acromion and humeral head, leading to impingement. Back in 1931, Codman and Ackerson suggested that degenerative changes lead to rotator cuff tears. Neer later classified impingement into three stages. Stage 1, edema and hemorrhage, common in patients under 25. Stage 2, fibrosis and tendinosis, ages 25 to 40. Stage 3, partial or full thickness tears, 40-plus years. Segment 2, acromion morphology and its role. Did you know that your acromion shape plays a big role in rotator cuff health? According to Bigliani and colleagues, there are three types of acromion. Type 1, flat, lower risk of impingement. Type 2, curved, moderate risk. Type 3, hooked, high risk of impingement and tears. Athletes in overhead sports, like swimmers, throwers, and tennis players, are especially prone to secondary impingement caused by GH instability and scapular dyskinesis. If the scapular stabilizers get fatigued, the synchronization between the scapula and humerus is lost, leading to more impingement risk. Segment 3. Clinical symptoms and history taking. So, how do you recognize rotator cuff pathology? Here are some key symptoms to look for. Pain in the upper arm, near the deltoid tuberosity and anterolateral acromion. Worse at night and with overhead movements. Weakness, stiffness, crepitus, and loss of endurance. Functional, catching, or instability. If a patient reports a gradual onset of weakness, it's likely a chronic tear. But if they suddenly develop weakness after years of shoulder pain, we suspect an acute on chronic tear. Segment 4. Physical examination and special tests. A thorough shoulder exam includes checking the cervical spine, neurological function, and opposite shoulder for comparison. Key areas to palpate include the AC joint, SC joint, subacromial space, biceps tendon, trapezius, and cervical spine. Impingement tests. Nair test, passive forward flexion plus internal rotation. Hawkins-Kennedy test, 90 degrees forward flexion plus internal rotation. Strength tests. Lift-off test, subscapularis function. Belly press test, internal rotation strength. Instability tests. Apprehension and relocation test, GH instability. Sulcus sign, inferior instability. Segment 5. Diagnostic testing. If special tests suggest rotator cuff involvement, we can use imaging to confirm the diagnosis. Common diagnostic tools include on-screen X-rays, rule out fractures, arthritis, and assess acromion shape. MRI, gold standard for detecting muscle atrophy, retraction, and bustle swelling. Ultrasonography, great for real-time assessment, but highly operator-dependent. Subacromial injection test. If lidocaine injection relieves pain, it's likely primary impingement. If pain persists with instability, GH instability is the culprit. Conclusion: rotator cuff disorders are complex, but understanding the causes, symptoms, and diagnostic approach helps in early detection and better treatment outcomes. If you found this video helpful, don't forget to like, share, and subscribe. And let us know in the comments, what topics would you like us to cover next? Thanks for watching Physical Remedy. We'll see you in the next one.